Delighted to introduce Irena Pukiova. And Irena is an advanced nurse practitioner in tissue viability from Oxford University Hospitals NHS Trust, and is going to talk to us about the impact of tissue viability service integrated in critical care.
Hello everyone, I would love to talk to you about a little project I undertaken here in Oxford, and it's about the impact of tissue viability ward round in critical care unit, and basically having critical care nurse or tissue viability nurse being part of the critical care team on full-time basis. What I would like to acknowledge is that this service evaluation has been conducted as a part of the NIHR internship at the National Institute for Research and Care Research at Oxford Biomedical Research Centre, BRC. So the views expressed are those of authors and not necessarily those of NIHR or the Department of Health Research Care. So just a little bit of a background. We know that individuals in intensive care units are particularly high risk of development of pressure ulcers due to range and complex pathophysiological mechanisms. All of this has been quite well researched in the literature. We know that ITU patients are very sick and usually necessitate sedation to tolerate all the tubes they have in, and they are immobilized because of the sedation, or if they are polytrauma patients, they might have other immobilization techniques in place. And as I already mentioned, alongside multiple medical devices that are usually delivering life-saving treatments, however, increasing the risk of pressure ulcers. Lately, in 2021, there has been really a good study, the Decubicus study, which actually was looking across European ITUs at the prevalence of pressure ulcers. And sorry, I think, can you see the slides? Can you see the slide?
Yes, I can see. Yes. The slide is the background. Yeah.
Oh yeah, brilliant.
The background on.
Thank you. I just missed something here. The prevalence of pressure injuries was quite high, to be found about 26.6%. And then the prevalence specific to ITU acquired injuries was about 16%. The sacrum and heels were the most affected body locations. And because I predominantly cover intensive care unit, I thought there's something quite not right with the numbers. That was the impulse to undertake the service evaluation. And of course, we have got many pressure ulcer risk assessment tools, but not most of them do really thoroughly identify those ITU patients who are at greater risk, which again might impede the measures. So the background to this service evaluation, it was across two hospital sites, John Radcliffe and Churchill Hospital ITU. It was in total 32 beds. And I included in this service evaluation about 192 nurses and 22 consultants, doctors. What is important to mention here is that the John Radcliffe Hospital is the regional trauma center, which played quite significant part in it later when I did the data evaluation. So our compliance with existing skincare protocol is on average 96%, which is done monthly. And the incidence of pressure damage remains prevalent at around 6.14%, which was pre-implementation phase. So you can see that we are already slightly below the numbers from multiple studies. So the project aims was to examine the impact of implementing an in-house dedicated tissue viability service for critical care. And amongst many objectives, it was to look at the pre-implementation data and post-implementation data of the tissue viability service, And what I was looking at specifically was incidence and severity of hospital-acquired pressure ulcers in critically ill patients, number of patients with documented pressure ulcer prevention care plan in place, Ulysses reviews for incidence of pressure ulcers and deterioration also, and a categorization of wound type and location across all patients to support prospective service provision and education strategies. What also I did collect some qualitative data assessing staff knowledge and confidence in managing tissue viability issues in critical care patients, which was collected through a questionnaire. So you can see the pre-implementation phase. So the pink number is how many patients we had in that month. So you can see that July was 142, and how many patients developed hospital-acquired pressure damage. So out of 142 patients, 15 patients in July, then we can see slightly more patients during summer in August, and going to September, I think it was a peak 157, but only 8 patients developed pressure damage. And October, we had less patients and only 3 patients had pressure damage. And okay. Can you see the slides now?
I'm seeing them. You're on the
I'm seeing them, Sarah. And I guess a few people are saying that they're seeing them. So
yeah.
Solid good.
Can I continue?
Please continue, Irena.
It's always my worry that the technology will fail me.
No, you're absolutely fine.
Yeah. So and now the next slide is so I will go back to the one because I think so. The pre-implementation, you can see it was 6.14% incidence, not prevalence incidence. I wanted to know exactly the data, what's going on the unit. That's why I opted for incidence, and also because I had a smaller cohort of patients. And then the results post-implementation phase dropped down to 3.65%. And you can see the average of patients monthly is about 140 patients. So you can see spike in December and January in incidence of the data. That was purely down to winter pressures and patients being admitted with flu, ARDS, and needs to be nursed in prone position. So that plays a significant part, I think, when you have an increase in incidence of pressure ulcers, especially in the winter months across critical care units. I think that is one of the reasons, or maybe on a standard wards as well, because they might need an IV. So this is the graph to look over 8 months, and we can see that we are sitting somewhere around 4.90%, which I think is quite nice, and with the peak in winter months. The drop in October, I think it's because I officially was supposed to start from November, but I was kind of around on the unit from October time. So that explains probably the drop as well. What really struck me during this service evaluation was how many incorrectly reported incidents there are. And the misclassifications is about 31.15%. So there was total of 183 incidents, and out of the misclassified, we had 57. You can see, and that again in the literature, there's not much attention to paid to this, but we have 28 category 1 categories reported, and nine of them were incorrectly assigned as a category 1. But when you look at the suspected deep tissue injury, that nearly mirrors the category 1. So we had 22 SDTIs reported, but only 9 of them were SDTIs. So what I could see from this trend is clearly that we are making mistakes mistakes in like correctly classifying category 1 and SDTI, which I think might be sometimes quite difficult. So another one, anatomical locations of HAPU. So we obviously didn't align with the decubicus study at all here, because our most prominent or most favorite location for pressure ulcer development are the nostrils. So left 1, 9 and right 8. Then is the occiput, and that goes with what I said. It's very important to mention that we are trauma center, and the occipits, all of them were from collars. And then we have got sacrum, which aligns with the study. And then you can see other anatomical locations like abdomen from prone in 1, or ears of 3 of them. Not many heels, I would say. That was really good, really reassuring. Another quite important slide, I think, which goes with the workload and probably staffing levels, is how many patients we actually admit with pressure ulcers and how many patients develops the hospital acquired pressure ulcers. And I would say that we actually, it's just slightly more. We admit with pressure ulcers rather than we cause them. What is quite important here, and it doesn't show through the data, is actually when we admit with pressure ulcers, those pressure ulcers are usually category 3 pressure ulcers, much worse than the hospital acquired in terms of category. So I think this is really interesting to see as well. Now I would go to the questionnaires. So the questionnaire was online, and it was sent to the staff who worked on the unit for more than 1 year, to staff nurses, physio, also included doctors. But from doctors cohort, I only included consultants, because they don't rotate around the unit like the registrars do, or other like SHOs might do. So you can see that just only one person rated that they have excellent knowledge in pressure ulcer prevention, and the same kind of same is for the categorizing. People would think they need further development, or their knowledge is acceptable in terms of knowledge in categorization of the skin damage. This was a very important slide for me to realize when I do design education, that actually nurses are not interested in virtual theoretical teaching, and they want to face-to-face or theoretical teaching, and also they want practical sessions and workshop. You can see that quite strongly 11 and 13 were for the practical sessions workshop, 1 for virtual teaching. And what we started to do on our unit is shadow shift with tissue viability nurse, so and one-to-one teaching at the bedside, which is part of the ward round, and they really liked that, which was very reassuring for me. And then if we have some interesting case studies, I usually email them to staff, so that is quite preferred option too. It got 5 responses for that. Also blended learnings got 4 here. What is very sad is that the question number 13, do you get protected time to attend tissue viability study sessions? Yes is 0, and 15 answers is no. So I think there's some responsibility perhaps, or redesigning of education sessions for the trust to think about if this is a harm-free care and priority of all NHS hospitals. Perhaps we need to probably give more time, protected time, to attend tissue viability study sessions. When we look at what resources are available to you in your daily practice, and what kind of resources do you prefer to use? So the colleagues were the winners here. Then the bleep or phone tissue viability nurse was the second one, referral via any electronic system or EPR. And resources on the tissue viability SharePoint site were number 4, and number 5 resources on MicroGuide ERLAS, which is our app, and internet search for evidence was number 6, and other forms were number 7. I will pause for about 1 to 2 minutes, and I will let you to read the feedback which was part of the questionnaire. What kind of impact people felt in words had to have a tissue viability nurse within the critical care team. Are you happy if I move to next slide?
Yes, I'm sure that's fine, Irena. Thank you.
Right. So also what I had as a part of this service evaluation shift was observational notes, or my kind of thoughts, little diary. And what I could see directly from my end, how I'm contributing, it was that I can influence the practice in a real time. It also, the collaboration approach was a huge element of this, that you are not just always in a reactive mode. When there are things happening, you get referral and you go and react to it. It was more proactive. And that really bring me closer to the nurses. I got much bigger engagement from the staff. I felt it was more collaborative approach than always reactive leadership. There was continuous learning together. So I'm still part of the critical care team, and you can see that impact is lasting. I would say that none of the pressure ulcers would deteriorate. So we had also improved healing rates on those one who were admitted with. Some of the patients we were discharging with healed pressure damage. So I think that was really important. Also, you could challenge poor practice at the real time. When you do one-to-one ward round, you ask questions, you bring up discussions, and also it was opportunity for the nurses to share their observations, which I think all led to quite high quality care. So I'm just gonna click to the next slide. So the discussion and conclusions, obviously what we've seen in numbers, although it was very small, small service evaluation, only kind of was looking in a total of 8 months, we could see that there was a significant drop in hospital-acquired pressure ulcers by 40.5% in total. And I think what the service evaluation demonstrates is that presence of tissue viability nurse has positive impact in reduction of harm, compliance with unit protocols, and increased staff engagement and knowledge. And I think the last two ones, the compliance and the engagement, were quite important one. Obviously, further studies are necessary to achieve clearer understanding of the incidence characteristic and the processes of reporting and validation concerning pressure injuries. I would say the classification of skin damage and pressure injuries presents a significant challenge, and I can see that someone was already posting that as a question. And I think the time invested in and the quality of education for healthcare professionals focused on essential pressure ulcer and wound management do not align with the requirements necessary for effective clinical practice. So by that, I mean that there's at the pre-registration level, at the uni level, when you are a nurse, student nurse, there's not really many hours spent on lectures or sim education around pressure ulcer and wound management, and then we are kind of playing up catch-up game in a hospitals, but you could see that we're not getting protected time, so that is a little bit of a problem. As I said, this evaluation had some limitations. One of them was that the limited time frame. The service evaluation project was overseen by a sole person, and the timing of the project was run during winter season, and the quite low response rate of questionnaires played quite significant part as well. I would hope for a slightly more engagement, and the pre-service implementation validation data are less robust compared to the post-service implementation validation data, because most of them I had to validate off the photos, but the one when the tissue viability was present was validated from the photos and in person. So the recommendations, we are continuing to collect the data in a database designed, and I will be looking in the future for larger project, including all intensive care units, and the educational strategies and time given for education needs to be revisited as a part of the unit or within the trust. And it would be really nice to also develop categorization and decision-making tool that incorporates differential diagnosis supplemented by photographic evidence of skin damage about categorization of pressure ulcers. And perhaps we would love to repeat the same service evaluation in the ward area with the high incidence of pressure ulcers and referral rates, which is not critical care orientated. There are some references, and thank you so much for listening to my presentation.
Thanks ever so much, Irena. Really interesting piece of work that you've done there. If you wouldn't mind, just that's fantastic. There's been lots of comments, questions. I'm just going to go up to the top and let's have a scroll through. Yes, people, because that slide that you did around where maybe the pressure ulcers haven't been categorized properly, it's just a comment someone made. Sometimes it is hard to classify at times, isn't it? And I suppose, it all tallies with your slides on access to education, where people aren't being given protected time. But I suppose that's in a formal education setting, whereas obviously where it seemed to work really well is when you're working with people alongside nurses in a clinical setting. I suppose that's a great form of education, getting the categorization right, isn't it?
Yeah, I would think it's a big question mark here, because even if you would have, I could guess 10 tissue viability nurses and you would have to agree on the categorization, you will never agree.
No.
All 10 people. So then my question kind of led me to question in practice how we expecting people to be always right when they report the incidents, if the professionals can't agree sometimes. So that is a big question mark for me, and if I only know how to solve it completely, I probably would do. So I think that is interesting topic.
Yes, definitely. When you had the slide where you were looking at pressure ulcers on admission to the hospital, Susan has asked, were these identified in A&E or once they'd got up to the ward?
So they were usually identified in ED if the patient came through ED, or if the patient came from the hospital ward, then they were usually already reported as an incident on a ward.
Okay, thank you. Someone wants to know, the person who said that they had good knowledge, categorization, and was it the doctor or was it a nurse?
So I don't know from top of my head, but I'm sure I would be able to find this answer for you from the top of my from the questionnaires. But actually thinking about it, probably not, because there was an anonymized questionnaire. It just they had to put what they are. So I think I would be able to find if it was consultant or nurse. Yes, but I don't know. I would think from my again observation. I don't think that consultants would put this.
No, probably not. You never know, but yeah. So thinking about skill mix then, those that sort of were involved in the study and sort of filled in the questionnaires, were there nursing assistants, or I mean, a range of titles now, isn't there? But because someone's asking, were they included in the study? If not, why?
Yeah, so they were not included in the study because in critical care unit, the nursing assistants only help with repositioning the patients. They will not have access to the documentation to document the skin damage. Therefore, they were not included for this reason.
Okay, that's fair enough. Okay. So someone's asked about the tissue viabilities, were they critical care based? I mean, we're talking about sort of your role here as part of that critical care team. So I know you've got a wider tissue viability team in Oxfordshire acute sector, haven't you?
So because I have a critical care background, I was placed in critical care unit as a tissue viability nurse. So actually, before joining the corporate team, my role was dual role, working as a critical care nurse, senior critical care nurse, and the other part of my job, I was working as a tissue viability nurse. So it's kind of like hybrid, which understands both world. And then when I joined the main team, obviously I was working as a tissue viability nurse, but always predominantly was covering critical care areas.
There's a question about different skin tones, because I know we talk a lot about that when we're doing skin inspection, and sometimes the difficulties of identifying maybe red areas, etc., etc. So were patients with different skin tones included in the study? Because yes, we know it can be difficult to identify, stages of damage.
So all the patients admitted to intensive care unit age of 18 plus were included. So I could not select who I include. It was all the patients admitted to ITU, and I know there were some patients with dark skin tones. So that was not selective, that I could select patients. Everyone who went through intensive care unit, and that was the admission rates, the numbers were included.
Right, thank you. Similar sort of questions about skill mix, etc. I'm just scrolling through here. Just a comment that tissue viability nurses are vital to improving patient care and prevention of pressure ulcers. And I think the model, that slide where people, the preferred sort of education, interestingly, 0 was e-learning.
Yeah.
I can relate to that. But there's differences between e-learning and maybe sort of virtual education such as this. I have to say that because obviously we're delivering lots of virtual education, and the opportunity to ask questions, to have discussion. It's a live event, whereas e-learning, yeah, it's right or wrong. You have to sort of be quite disciplined. But that sort of, clinical facing, working alongside somebody with a patient, it's such a great opportunity, isn't it, for learning as well.
I would also think, Sarah, I think like event like this one today is brilliant for clinicians who are having the topic they know a little bit, and they can kind of relate to it. But if you are learning something new, I think they find it quite difficult to be in a virtual environment. And also tissue viability is quite practical subject. So I think that's why they like the one-to-one and to be somewhere safe where they can kind of maybe touch the models or look at the documentation in a real time and try by themselves. So that was kind of the feedback. So I think it's quite interesting to see that probably for different groups of nurses, like if you specialist nurse, this event is absolutely great because it has you can reach pretty much anyone within the UK and beyond if you would like to. But if you want to really teach something basic or something new to the nurses, I think they really prefer face to face. And I can see that in the shadow shifts, because you would assume they know things, but sometimes they even don't know how to document things correctly, because there's so much information kind of thrown at them when they start in a trust that I think they get slightly cognitive overload,
Yes, you're absolutely right. Yeah, yeah. There's so much, isn't there, to keep on top of in terms of, you know, even the non-clinical learning that we need to go through, you know, that's mandatory, and it does get overload, doesn't it, really? Someone's asked about if the patient is on end of life care and has developed pressure ulcers but not, you know, eating and drinking enough, not fully alert, does the patient still need TVN input? What are your thoughts? I mean, we're talking critical care here, and every patient should have access to speciality, shouldn't they?
So I would think from my point of view, yes, there were patients who were palliative pathway, but because it's critical care, it's very quick. It's not that we function in the same capacity, like for example, some of the end of life wards would be, which are designed for that purpose. We probably would be switching off the supportive treatment, and the patient would have died within 24 hours.
Mm-hmm.
And then in some cases they are still fed, some cases are not. It really depends what is the trajectory and why they've been palliated. Some of them might go for organ donation. So all the patients were included, and all the patients had the tissue viability ward round. If that helps, if I answer that question.
Yes, you have. Thank you. Someone's asked about cost savings in reducing pressure ulcer damage. It would be interesting to see costs saved in reducing pressure ulcers during the period of the study.
Yeah, so I think it's a very good question. But as I said in my recommendations, this would have to be much larger study of much bigger scale and over longer period of time. Given the fact that I done this only within limited period of time, and I didn't have a big team to do that, just my supervisor and myself, I think I would not be able to do that, because I would need to have other teams like financial advisors and economists to do that. But if I'm lucky enough and will progress in my career towards a bit more academic pathway, then I think study of this kind will definitely be something I will be looking at.
Yeah, thank you. A clinical question about negative pressure treatment for end-of-life patients. I'm not sure if they mean, you know, using that therapy if someone maybe has say a category 4 pressure ulcer. I'm not sure if the question is relating to pressure ulcers or wounds generally. But just a comment if you feel you can.
It depends. Is the person, can they go and probably specify the question a bit more so I know what to answer?
They've just said here, have you used VAC dressings, obviously that's brand, or on end-of-life care patients?
So as I said, the end-of-life care in critical care is slightly different. So yes, they would have, if they had, let's say, polytrauma and they would die of head injury, yes, they would have that dressing. But I suppose your question would relate to, let's say, if we go to proper palliation wards. So yes, there are instances where you can use it, but you have to have a good reasoning for it. So let's say if you would be using back dressing on deep category 3 or category 4 pressure ulcer, because you have got loads of exudate, and it's much more easier to change the dressing every 72 hours than to do every day because of exudate. Then that would be a good practice, because you are using less resources, the patient has got less pain. There's also now a few studies showing if you have a wound with cancer cells, you could use a negative pressure therapy if you explain to the patient that really they are on a palliative pathway and you are not treating them. It's just for management of symptoms and again pain exudate. Then there are cases described in the literature now where the NPWT was used with a big success. But you have to be very, very careful about your assessment, and this has to be MDT decision. You can't just go on your own and do it, especially if the patient's got cancer and it's palliative.
Yes, and I think that there was some clarity around that question, but yes, I mean, obviously when we talk about end of life, you know, I was always guided that if, you know, it's not necessarily the last days or weeks of someone's life, it's, you know, if you're surprised that that person will still be alive in 12 months time, that is probably your end of life definition. So I think they were saying yes about maybe management of symptoms like exudate and stuff like that. So yeah, you've answered that really well. Thank you. That is a really interesting piece of work you've done. And I think there's, as you said, there's still more to be researched, isn't there? And maybe bigger cohort